When building our families, we so often worry about egg health, and that's understandable. But what about sperm? Should we be thinking about our sperm health more? Should we be eating a certain way? Should we be testing ahead of time? What should we be thinking about with regard to sperm? Well, today on this episode, we're going to answer all those questions and more with Dr. Justine Witzke. She will tell us everything that we need to know about sperm health and how to plan for your future family. Welcome to Building Your Family. This is a podcast about donor conception, surrogacy, fertility treatment, and all the ways the modern family is built. My name is Lisa Schumann. I'm your host. I'm an author, a researcher, and I'm thrilled to be here to help you understand so many things. And today, specifically, we are going to talk about sperm health. So today we have a woman named Dr. Justine Witzke from Aligneage Fertility. But before that, she has a long history of working in this industry. Justine is an experienced strategist and operator, having served in a variety of roles, including head of clinical operations at Weill Cornell Medical Center for Reproductive Medicine, which is a huge fertility practice and one of the most well-respected in the country. She's worked in fertility preservation, helping expand LGBTQ services, and managing the department's COVID-19 response systems. She cares deeply about educating patients, colleagues, and the public, and somehow finds time to volunteer for so many wonderful organizations as well. She's a fantastic human being and a wonderful professional, and she's opened this fantastic fertility program, Aligneage Fertility. It's a fantastic program to help people test and freeze their sperm. And I want to tell you all about it. So I'm going to introduce her now. Justine, thank you so much for coming.
Lisa, thank you so much for having me. I really appreciate it. Thank you for the kind introduction. It's a privilege to be here, and I know you're doing so much good of sharing so many different parts of our field with your listeners and with patients over the years. So thanks.
It's my pleasure. I really love having you here. And I really love the idea of you sharing your wisdom with our listeners, because there's so many difficulties that patients face when they don't know what to do. And sometimes they don't know which questions to ask. And so today I thought we could start by talking about some of the misconceptions that people have when they think about sperm health, because you see these issues every day. And I thought you could really help educate our listeners. So can we start there?
Absolutely. So I would say, like you mentioned, I've worked in this field going the better part of 20 years at this point, and I got to work at a very large, very well-respected IVF program for so long, with access to some of the most world-renowned professionals in our field. What a privilege to have been trained that way. And a couple of years ago, I started Aligneage Fertility, which is a sperm bank and fertility consultancy here in Midtown Manhattan. And like you said, we do sperm testing, we do semen analysis, we freeze sperm for people's future use. Sometimes that's because they're having a medical procedure, maybe chemotherapy, maybe they're having gender affirming care, something else going on. They want to freeze sperm for their own future use. Sometimes they're serving as a sperm donor to a friend or a family member. They need the testing and screening that is dictated by the FDA and the Department of Health to reduce the risk of transmitting infectious diseases between donor and recipient. Sometimes they're working with a gestational surrogate, and that same sort of testing and screening is needed so that the surrogate is protected. So we do quite a few different things. We're also recruiting sperm donors for a boutique sperm bank. In the course of this, we see lots of semen analysis reports. We talk to lots of patients with different indications of why they're here. Some of them have been experiencing infertility. Some of them assume they're fertile, right, before they walk in and have never had a semen analysis before. But one of the things that kind of comes up so frequently, and I end up having this conversation, honestly, probably daily, is that people who are born female are born with all the eggs they will ever have. And like a trivia piece of that is that we actually start losing some of those eggs before we're even born. They say that a 20-week fetus has the most eggs in the ovaries that there ever will be. So that can sound a little discouraging, but that rate of decline is pretty slow for quite a while. And then in the mid-late 30s, the rate of decline starts to increase. And that's sort of what we all hear about with age-related infertility. But for men, the spermatogenesis is about a 3-month process. So if they are, after puberty, they start making sperm. And if there are environmental factors, medical factors, physiologic things going on that might affect the semen analysis, if those things can be corrected or changed or eliminated, and we repeat a semen analysis 3 or 4 months later, we can really see a marked improvement in that. So that can be really, really useful. And for a lot of people, they come in just to do a baseline semen analysis. They're maybe 28 years old or 35 years old, and maybe they have a partner and they're not really ready to conceive yet, but they're like, well, why wouldn't I know what's going on? And if there's something significant, maybe I have now time to address that, maybe work with a reproductive urologist if that's necessary, or maybe they stop using cannabis products, or they adjust their workout behaviors, or they adjust their medications with their doctor so that they can improve the semen analysis and help their future fertility. So that's definitely a common thing that is a topic of conversation for us.
Patients find so often this struggle, right? And I'm sure you probably see in heterosexual relationships in particular, where women feel like it's all their fault and they're to blame. And sometimes rather than accepting that this is just nature and it's not about blame, it's easy to feel really frustrated and stressed and say, well, what about, the male? And there can be problems with the male, which we will talk about in a moment, but naturally, the sperm's going to regenerate itself. So even if we have a problem, if we fix it, we might have a chance of regenerating good sperm where we don't have that opportunity with eggs, right? And so I think this information is so important for people to understand that, yes, it is difficult to accept this about the eggs, but it's so hopeful to know about sperm that we can do these things to adjust our lifestyles and then have fresh new sperm that can be very healthy.
Right. For many years, I used to say to patients, they'd think like, oh, I'm starting my stimulation next week. Is there anything I should eat or drink? And I used to say to them, well, for better or worse, you can't change your eggs. They're going to be whatever they're going to be next week. So that doesn't mean, we should disregard general health, recommendations and those kinds of things. But if you don't eat the perfect meal every day the week of your stimulation, it's not changing your eggs, that kind of thing. So thinking about it that way can kind of help, at least to me, not feel so stressed about it because you can't control it. So let it be. But on the sperm side, we do have more control. And it doesn't mean every meal or every drink or even every substance use is deeply problematic. But if there's consistent, let's say, cannabis use, which is legal in New York, there's no commentary on people using cannabis, but it is a known thing that affects the semen analysis. And so if we do a semen analysis on somebody who regularly uses cannabis products and it's not great, maybe the count is low, maybe the morphology is low. The morphology is the shapes of the sperm. So I tell people to imagine a textbook or a cartoon, to think of the head, the neck, the tail from those pictures they see. Sometimes that's lower than what we would ideally like it to be for fertilization, for fertility. If there is something modifiable like that cannabis use or even cigarette smoking, that's something they can change. And then we can see if that's the thing that maybe is impacting it. So it does allow for more adjustment of behaviors and exposures and that kind of thing.
That's great. That's so exciting and nice to hear. And I think that while we're on this topic, Justine, just to kind of back up a little bit for those of you who are not familiar with what Justine is talking about in terms of these 3 issues that they look at to decide how healthy your sperm is. Justine, maybe you can explain that to the viewers.
Absolutely. So when we do semen analysis, we look at actually 14 different parameters, and that's what's on the report. But when I call people with the report, typically we're talking about 4 of those parameters as sort of most important out of what we've looked at. So one of those is the volume, so the total amount of sample that there is. And if that's very low, that can, of course, limit the number of sperm that are being available, but also could be indicative of some other kind of medical conditions going on if the volume is super low. we look at the concentration or the sperm count. So this is measured in millions of sperm per milliliter. So if someone has 2 milliliters of a semen sample, we're looking at how many sperm there are per milliliter. And the normal range for that is super wide. And this is also something that's surprising to people. And if I quizzed our patients, they wouldn't know what the normal range should be.
Mm-hmm.
But it's typically 20 million to about 120 million sperm per milliliter is normal. Someone could say, oh yeah, it's a normal semen analysis. They have 22 million sperm per ml. But if their semen analysis was 100 million sperm per ml, it would also be normal. And those aren't really the same when we think about it from a fertility perspective. So there's quite a wide range within that. Then the next thing we think about is the motility, which is the percentage of those sperm that are moving. And the normal range for that is we want it to be more than 40%. Ideally, we'd like more than 50% of the sperm to be moving, but it's considered normal if it's more than 40%. And within motility, we're also concerned about how those sperm are moving. Are they moving in circles? Are they twitching? Or are they moving what's called progressively, like they're swimming forward? And ideally, we want them to be swimming forward. And then the fourth of these kind of big parameters that we look at is the morphology that I referred to before. So that's the shapes of the sperm. And this is always shocking to people, but we're only hoping that about 4% of the sperm are normally shaped. It's always going to be a single digit. I think the highest I've ever seen is maybe 7%.
Wow.
But quite frequently, 2, 3, 4% of the sperm are normally shaped. A lot of this has to do with the math, right? So certain parameters being very good can sort of compensate a little bit for a different parameter not being so good. So if someone really does have 100 million sperm per milliliter and they have 60% of those sperm are motile, but the morphology is 2%, that's still more normally shaped motile sperm than if somebody had 20 million sperm with 50% motility and 4% normal shapes. So I kind of think about it as like the whole thing together, not any one parameter being the most important.
And that's great. And that's really helpful information and really fascinating. And I think it's also helpful for people to know that we really don't need that many sperm, right? Whereas we need to make a lot of eggs.
Oh, with IVF, ultimately we need 1 sperm per egg with IVF. Now, we want to have more than that to work with ideally, but with IVF, there are procedures in the laboratory on the day of an egg retrieval or on the day of an egg thaw. They will take either a fresh sperm sample or a frozen vial of sperm, prepare it, it's called washing it, and then put the sperm into a sort of viscous media in the lab, think maple syrup, right? Slows the sperm down enough that they can be visualized under the microscope. And the embryologist is actually able to select an individual sperm, this tiny, tiny, tiny thing, and use that for a procedure called ICSI, which I'm sure you've covered on the show before, intracytoplasmic sperm injection, where 1 sperm is injected directly into the egg for fertilization. So that can bypass a lot of male factor issues. Here's a great example. Somebody has, maybe it's a young man with testicular cancer. And by the time he was diagnosed with cancer and did his fertility preservation, the semen parameters were already really impacted by the disease. And, the sperm counts maybe 1 million sperm. And we would ideally like that to be that 20 to 120 million. That doesn't mean he can't use that sperm 10 years from now with IVF. They'll be able to thaw it. They'll be able to identify sperm. They'll be able to use it for IVF. And I think that's such a promising thing for people to think about. The flip side of this is often we'll see, especially I would say among single women who are planning to be single moms by choice or same-sex female couples who maybe have never been exposed to sperm, never attempted to conceive before, may want to start their treatment with inseminations or with IUI. And our thresholds of what samples are sort of suitable for IUI are much higher than what is suitable for using with IVF. Typically, there's sort of a rule of thumb out there that after all the processing, freezing, thawing, etc., that you want at least 10 million motile sperm if you're going to use IUI. But that means, if you start with 40 million and 50% motility and about 50% will survive the freezing and thawing, 50, 60%, you need at least like 40 million sperm to start with for that sample to be kind of suitable for IUI. Doesn't mean you can't do IUI with a lower count, but I think that's sort of the rule of thumb that's out there.
Yeah. And I think that's important also to know, just as a total aside, and we've kind of talked about in our lesbian family building episodes about this idea that it can be really helpful to think about that, because as you get older, if your chances for getting pregnant each month starts to decline, then you have to kind of do the math. Like maybe you want to use IUI and you think it makes sense, but we're not using free sperm.
Right.
So you have to buy the sperm over and over and over again, or ask a friend, if you have a known donor, to give you sperm over and over again. And that's a lot of sperm, as opposed to maybe using a process like ICSI that is more effective and maybe seems like it costs more, but in the end, it may be cost effective for you.
I think the cost effectiveness literature really supports going to IVF. I think that's been for quite a while at this point. Like people have studied that. That doesn't mean that, because of just somebody's sort of risk tolerance or willingness to pursue certain types of treatment, or sometimes their insurance coverage kind of encourages them to do IUIs first. There are lots of reasons why these things happen. But yes, the donated sperm is on some level a limited resource, right? There are only so many vials available to any one person for the most part. So how to best utilize that resource to build your whole family is a relevant part of the consideration, kind of the calculation, if you will, on what treatment plan makes sense.
Mm-hmm. Imagine your beautiful future. You're snuggling with your child. You feel so connected to them. Your friends and family are so happy, and you have everything that you've ever wanted. I want this for you too, but I want more than that. I want you to feel secure knowing that you've made the best decisions, not just short-term, but long-term, for your future family. Wherever you are on your journey, whether you're choosing a donor, choosing a clinic, learning how to talk to your donor-conceived child about their origins, all of these decisions will have wider implications for your future. And I want you to have the right resources so you can feel empowered and confident at this very important time in your life. That's why I'm so excited to introduce you to Building Your Family. It's the only expert-guided platform designed for parents and parents-to-be using reproductive medicine. We provide unique strategies that you won't find anywhere else to make your path to parenthood smoother and more informed. And that's why our approach is about offering practical and actionable steps that you can use right now. Whether you're just starting out or already deep into your process, Building Your Family is here to guide you with expert advice, specialized education, stress reduction strategies, and a community to support you every step of the way. We can't wait to see you inside. While we're on that topic, we're thinking about different ways to build your family and thinking about how you can kind of think about, sperm health and all of that. As kind of we go through this process, we very often are thinking, when we're using donor sperm, well, if there's an issue with the sperm, let's say we're in a heterosexual relationship and there's a problem that we know, maybe there was a cancer or some other problem. Or if we're a lesbian couple and we think, I just need sperm, or a single woman, I just need sperm. It's very natural. We're anxious because we're going through fertility treatment. We want to hurry up and have a baby yesterday, naturally, who doesn't? But it is very natural to kind of focus on the sperm so much that there's really not a lot of thought. And I think this is where, you come in, Justine, thinking about, well, is that sperm in good shape?
Yeah. So let's take, a case example of a single woman who wants to use maybe her childhood friend as her sperm donor, right? And really, maybe he has, kids from his own relationship and his own family building's complete. And he's like really happy, gung-ho participant in this new family building journey. What I tell, if somebody calls me and asks me like, how do I do this? How does he donate sperm? I kind of put the little pause in the process there. And typically I'll recommend that a bit diagnostic semen analysis and the genetic carrier testing are done first. And those two tests are kind of the way I phrase it usually is that they're the least expensive, least invasive tests that we can do, a semen test and a blood test. And they are probably the most likely to be sort of a non-starter in that whole process. Because if the sperm provider and the recipient are carriers for the same recessive disorder, likely the most logical thing would be to choose a different sperm source. If the semen parameters are really not good for whatever the patient's desired treatment plan would be, that's probably not something that he should be going to a reproductive urologist and, spending a tremendous amount of time and money and effort to work on that. Now, are there cases where that may be warranted? Sure. But by and large, we would generally say we want to see a good semen analysis and appropriate genetic testing before you then go to meet with a psychologist, go through the conversations, meet with a reproductive attorney, make sure the contracts are in place, make sure everybody's protected in this process, and then come back to us to do the actual regulated testing and screening and the actual donations. So it can be, maybe a month or 6 weeks of that sort of preliminary work before the donations actually happen. But I think in the end, those things are so important and ultimately will be time saving and cost saving at the end of the day.
Yes. And I think that's such a difficult thing for people to understand, right? That we see so many people on the internet saying, why do I have to do the genetic testing and the psychological consult and the sperm testing and I like this guy. He's my best friend from college. I know him really well and it's going to be fine. Don't worry about it. And we don't know if any of those things are going to be fine. We don't know that there's not going to be some genetic issue or complementary family historical issues or some problem with their future relationship potentially, or if there's a problem with the sperm, right? Because, right, we're talking about the difference between sperm and eggs. And here you have somebody whose eggs are getting older as they're trying it month after month after month. And what if there's something wrong with that sperm? You wouldn't know.
The eggs are ultimately a limited resource, right? There are only so many reproductive years. And for every person, that's sort of an unknown period of time, right? We don't know at what stage fertility treatment and fertility will time out each individually. We have population-wide data to support sort of some numbers and thoughts and ways people think about this, but none of that's really applicable to any one of us as an individual.
Right.
And so if we were to, let's say somebody just is like, I just want to screen this donor, I want to do inseminations next month. But then you come to find out that the semen analysis is really not good and it's not really appropriate for insemination. And now you've expended this tremendous amount of resources, right? And I use that term all the time, but to me, it really means all the things. It means money, but also time and your emotional effort and your physical effort and all the things that kind of go into doing this. And I mean, I said to a patient yesterday, you spent a lot of effort even getting to this point, right? Getting to the beginning takes a lot of effort.
Yes.
And we want to make then these kind of practical steps in it as palatable and as approachable and as understandable as possible. So that's really a lot of what we try to focus on.
And that's so helpful to kind of really think through all of these things before you kind of dive in, because so often patients just dive in and then later they have to backtrack and say, okay, now, something's going wrong. And sometimes it's too late, right? Sometimes there are issues down the line and we don't want to be saddled with problems or get to the place where our eggs get older. And now we've discovered that the sperm donor that we chose doesn't produce good sperm or doesn't produce any sperm. And now all of a sudden we're 2 years older and we have to start from scratch.
Or I think of a case of somebody like thawing frozen eggs and fertilizing them. And maybe those are the only eggs that are going to be available to them.
Mm-hmm.
And that really is such a precious resource. And we want to make sure that we have everything in place that they will feel comfortable and confident using those embryos, both clinically and socially.
Absolutely. So, what can people do to try to improve or give themselves the best chances of having healthy sperm?
A lot of this sounds so silly because it's like the stuff we probably all really know we should do. Like limit the amount that we drink, limit the amount that we smoke, eat a generally healthy diet, stay pretty hydrated, exercise, but maybe don't train for the Tour de France, right? Like extreme
Mm-hmm.
exercise, extreme use of hot tub saunas, those kinds of things can be impactful. Does that mean you're away 1 week skiing and you shouldn't go in the hot tub? No, that doesn't mean don't ever go in a hot tub. But if your workout, routine involves sauna and cold plunge and hot tub every single day, then that maybe is impactful, right? So
Mm-hmm.
I try to really use a lot of like logic when I think about this of
Mm-hmm.
like anything within reason is probably not going to be so bad. On the extremes, we can really have a lot of impact. But some things are very surprising to people that impact sperm. So I think there are kind of two schools of thought on this. I think some people know, oh, for sure, I knew that. And other people are like, I've never heard that in my whole life. Is that they'll take testosterone supplementation. And on the
Mm-hmm.
surface, a lot of people might think like, oh, that's going to help my sperm because testosterone is related to spermatogenesis. But exogenous testosterone or taking testosterone actually makes your body make less testosterone and ultimately make fewer sperm. And over time, some people will lose spermatogenesis entirely if they're taking testosterone. Sometimes that'll come back if they stop. It doesn't always come back. And it certainly
Mm-hmm.
doesn't always come back to the levels that we saw prior to starting the treatment. There are some other medications that have less of an impact, some hair loss medications, which wouldn't be, something that the general public would necessarily know would be related to spermatogenesis. So the way I think about it is that all of these other providers who are prescribing testosterone or hair loss medications or, endocrinologists who are working with patients, they don't necessarily have to be the fertility expert. They don't necessarily
Mm-hmm.
need to be the one who knows how to counsel somebody on ICSI. But they should, I think, be having a conversation with them of, are you interested in future fertility? These are
Yes.
things that we kind of know can affect
Yes.
fertility. Maybe you should look into fertility preservation. Maybe you should at least get a baseline analysis, see what we're working with now. And that baseline analysis, I think, is something that a lot of people could do to give themselves some peace of mind without it being that we're doing testing for no reason. But even if you're, not quite ready to try to conceive, but you know that that's in your future, if you do a semen analysis today, does it tell us that you'll for sure have sperm 2 years from now? No. But if it's bad today, then we have time to
Mm.
work on it, see a urologist, see what's going on, in your life that might be impacting it, and see what will feel most comfortable and you'll feel best about for a family building plan in the future. And you and I talk about this all the time, probably every time we end up talking, that if you want to be a parent, there's a way to be a parent, but it
Yes.
doesn't necessarily look exactly the way you imagined it to look ahead of time. So the more information we have, the easier it is to kind of go through these steps and feel really good about whatever path to parenthood you take.
Mm-hmm. Yes, absolutely. And, I think it's so important for people, to hear this and to think about that it's not, there's no reason to really panic if you plan ahead, right? You want to start your family at some point, get the information, get your workup with on your eggs, on your sperm, figure out what's going on. And so if you get to a place where you think, okay, I'm ready to start my family and something doesn't go right, no matter what it is, you don't have to scramble because you
Right.
already have some idea, as you're saying, and you can do things proactively, right? As you're saying, if your doctor says, I really think that you have to stop using hot tubs, right? Maybe, the sperm, the testicles are outside of the body for a reason. You can't get them hot, right? So we have to really think about trying not to do that for a little while. And then you can say, okay, I can abstain for a little bit, freeze my
Right.
sperm, right? So I think that that's a really great point and important for people to hear. And we prepare for so many things in life. Why not prepare for family planning?
Exactly. One of the things I think about, and there's sort of parallel on both sides, I remember telling so many patients, like, why not do the consult with the reproductive endocrinologist, right? Get an
Mm-hmm.
ovarian reserve test, have them look at your uterus, have them look at the ovaries. Let's say there's a fibroid in the uterus and they think you should have surgery. And now that's going to be time to schedule that, time to recover from it, time before
Yes.
you're able to have a transfer. On the male side, some patients, they have not a great semen analysis, and it's then determined that they have a varicocele, or basically a varicose vein on the testicle. And that works in that same mechanism as the hot tubs. Is it increases the temperature of the testicle and then can detrimentally impact the semen analysis. But there are procedures that can improve the varicocele and ultimately improve the semen analysis in many patients. But that again takes that time. You have to have that diagnosed. You have to have the procedure scheduled. You have to have the procedure, recover, and allow for a cycle of spermatogenesis. So if you are thinking, oh, I want to, start trying to conceive next month, now all of a sudden we've pushed that out 4 or 5 months. And now
Right.
that can be, emotionally challenging and disappointing on day one, right? Before day one, now you're disappointed.
Yes.
And I think that's, if that can be avoided, it's great to avoid that.
Yes. I think that's so hard to wrap our minds around. Like, I don't know if it's a societal thing or it's just that we're moving into more technology and we have to wrap our minds around it. Maybe it's hard to think, well, I want to be romantic. I just want to try at home, or I just want to try the first time and not think about these things. But if we can really embrace technology and embrace all this wonderful knowledge and information that you're sharing, then we can arm ourselves with all of the things that we need to prepare for our future.
Most likely, if we did a semen analysis, it's going to be normal and we're going to give you good news. And that actually does maybe the reverse, right? Then you can
Mm-hmm.
think like, oh, I feel very optimistic going into this, right?
Mm-hmm.
So I think in fertility, we end up talking about these sort of less than preferred outcomes quite frequently. But across the population, if we just did a semen analysis on everybody, we're probably going to get more normal semen analyses than abnormal ones.
Right.
And so, I don't think it's something that people should be so fearful of. But if there is something significant that we pick up, wouldn't you want to know? Right?
Yes, absolutely.
Yeah.
Absolutely. Well, that's great information, Justine. I really appreciate it. Are there other things before we start to wind down that you think that people should know that you find that people generally don't know?
So, I mean, this is sort of a slightly different, maybe less clinical part of the field that we work in, but we've referred to surrogacy and known sperm donation and some of these things that are parts of the third party reproduction umbrella. And I think one of the things that gets me sometimes when I listen to the media talk about our field is that it's as if there are no regulations and that this is the Wild West. And
Mm-hmm.
as it turns out, there are a tremendous number of regulations.
Tremendous.
The FDA, the federal government, in New York, the New York State Department of Health, in many other states, the departments of health have specific regulations on how this is done. The American Society for Reproductive Medicine and other professional organizations have guidelines and recommendations. And all of these things are designed to be safety mechanisms, right? They're designed to reduce the risk of transmitting infectious diseases between donor and recipient, or donor, intended parent and surrogate, or to make sure that there is sort of a facilitated conversation among a group with someone like you so that everybody has appropriate expectations going into what this process is going to look like. And that's what these guidelines and these regulations are intended to do. They're not intended to be discriminatory or make this harder than it has to be or any of those things. They just are part of our work. And I think that's why it's so important to work with a team of fertility specialists who are accustomed to doing that work, who really understand those rules and can help patients navigate that kind of unknown regulatory landscape. To us, it isn't unknown. This is what we talk about every day with everyone. So I guess I would say, like, don't be afraid of the regulations. They're there for good reason. And we're able to build a family for anybody through these technologies. So it's just a matter of kind of being creative. And sometimes it takes 50 steps instead of 5 steps, but that's okay.
That's okay. And I think it's so helpful, right? Because I think in reproduction, it seems that we look at it so much differently than so many other areas of medicine, right? We feel like, oh, well, there's something wrong if we can't get pregnant right away, or we need help, or we shouldn't need help, or we shouldn't use artificial insemination or some other way of getting pregnant that maybe isn't, our first choice. And so people feel so worried and defensive and anxious around it. But in other areas of medicine, if there's, a flu vaccine that comes around that takes care of a new flu, we're very eager to embrace it for the most part. I mean, not everyone feels that way, but most people feel like, yes, I want to embrace this new technology because it's going to keep me healthy. It's going to keep me safe. And I think that we really need to embrace reproductive medicine in that way. As you're saying, Justine, right now in this country, fortunately, and hopefully things won't change, but right now in this country, we do have a lot of regard for our health system and all the entities Justine is bringing up that governs it. And the American Society for Reproductive Medicine governs themselves, fortunately, because their guidelines are actually more strict than we could even imagine, being part of the national system. And we all really try to abide by them because they're very thoughtful, and there are lots and lots of well-meaning physicians and specialists like Justine and myself who do everything we can to really try to make sure that we follow everything that's helpful for you. So when you come into my office or Justine's office and say, oh, it's no problem, people get pregnant at home every day, but there are babies born with problems every day. There are people who are disappointed because they can't get pregnant every day. There are all sorts of difficulties, and our goal is really to try to minimize those difficulties to the degree that we're able.
I completely agree. I think probably thousands of times in my career, I have said to people, well, if you broke your arm, you'd go to the doctor. So if you need fertility treatment, you go to the doctor. It's really, it's all the same to me.
Yes, absolutely. I'm singing from the same hymn sheet, Justine. Yes. It's so true. It's so true. Well, it's so wonderful having you on this podcast. Thank you so much for coming. Is there a way that people can reach you?
Absolutely. So you can find our website. It's aligneagefertility.com. And since it's a little complicated, I'll spell it. It's www.aligneagefertility.com. And we're also on Instagram at Aligneage Fertility. And if you call, pretty good chance I'll answer the phone. So I'd love to talk to anybody. We certainly see people for all of this andrology related work, sperm freezing, semen analysis, fertility preservation, the donor testing and screening. And we also do kind of individual and group educational consults. So if somebody really just hasn't the faintest idea where to begin, we can spend some time, go through all the options that sort of exist out there in the world and help them in that decision-making process too. So we have several options for everybody. There are a lot of right answers to every one of these questions. So
that's wonderful. That's great.
Yeah.
Well, thank you. And all of you out there, please take Justine's information and reach out to her. She is a wealth of information and so well trained and so knowledgeable. It's really worthwhile getting the right information from the right people. And I'm so glad that you are listening today because you're helping yourself on your path to parenthood. And that's all we really want. So thank you for joining us. And I hope that I see you next week.
Thank you for having me.
You're welcome. Hi, it's Lisa Schumann. I hope that you enjoyed that video and I hope it helped you. And if it did, please give us a thumbs up and subscribe because that's how we keep going. It's really important to us. And if you liked it, you might like this one.